Good afternoon. Welcome to Who's Tom and Dick? With your hosts, Martin Weavers and Patrick Mortimer. Hello Martin, how are you today?
Hello Patrick, I'm on top of the world.
Oh good.
Yeah.
Happy New Year to you.
Yeah, Happy New Year to you too. And,
First broadcast of 2024.
yes, exciting. Did you have a good Christmas?
Yep, very good, thank you very much.
Good, yeah.
I'll have to explain that this is our first outside recording, isn't it?
It is. It's exciting, isn't it?
It is exciting. We're actually in the West Suffolk Hospital in Bury St Edmunds, so you may hear some background noise, but that shouldn't worry us too much.
Shouldn't put us off, but we're very pleased that we've been mentioning this for quite a while now, and we've got special guests coming in.
Yes, well, I mean, this episode is going to be really all around our special guests, so perhaps you'd like to introduce.
I will do. We're pleased to announce that we've got Dr Dan Patterson here. So good morning to you.
Hello,
good morning.
Happy New Year.
Yeah, Happy New Year to you, and thanks for coming in to do the interview with us this much. This is basically the man that saved my life. But what we want to do is ask Dr. Patterson basically where it all started. Where obviously you was a junior doctor, I suppose, at one point, and then you was tell us your life story.
Yeah, well, I decided to go into medicine at the age of 14, 15, having had a number of childhood problems myself, so I was very grateful for everything that was done for me, and I wanted to pay that back. And so I qualified in 1996 in London, and then you go through several years as a junior doctor, and I soon realised oncology, cancer medicine, was the thing for me. I haven't enjoyed it at medical school, and then become a registrar, which I did in London, and then eventually a consultant in 2009. So it's a hard slog to get there, but now you get to that top. It's a wonderful, rewarding job. You have the ups and downs, and it's a very exciting time to practice oncology with all these exciting drugs like what we've used for you, and we're seeing truly amazing results. Yeah.
So where in London was it that you was at?
So I trained at University College London, so in the centre of town, and then when I was a registrar, went back to UCL, and then also the Whittington Hospital in North London, Mount Vernon, and then a year at the Lister. You certainly go to a number of different places, and you build up your experience in what you see and do in the different hospitals. And
these are certainly names I've heard of, but it's nice that I've now met someone that actually has gone through all that. So from start to finish. Before you did your first sort of oncology ward here at West Suffolk, did you do other wards elsewhere? Was this your first here?
So I was a locum consultant on the South Coast for 2 years before I came here.
So from the start of your training to that position, how many years?
That was 13 years.
13 years. Wow.
Yeah.
It's amazing, isn't it?
It is, yeah.
Yeah,
if you add in the 6 years of medical school, then that's 19 years. So it is a hard slog.
So how long are you actually classed as a junior doctor?
So that's basically up to becoming a consultant. So the traditional name for a house officer, senior house officer, registrar, it's slightly rebranded now. They're called Foundation Year 1 and 2. Then you become a medical trainee, which is a bit like a sort of senior SHO level, and then registrar. So,
right.
So once you become a registrar, that's normally 4 to 5 years.
Yeah.
Plus, if you add in research that many oncologists do, then that's why it takes, on average, probably between 10 to 13, 14 years from qualifying to eventually becoming a consultant.
Okay.
That really has surprised me how long it takes. But I've heard the word registrar because I've known two since I've been coming in here and all that, and they seem to have a vast knowledge as well of everything that's going on
Well, they're like my number two, so they're there to learn from the consultant, but and they're sort of like serving their apprenticeship to learn, and one day they'll be a consultant. So, so our current registrar will be qualified probably in 3 or 4 years' time, and then they'll be like me. So.
And there is another oncologist here, isn't there? I've seen somebody else.
So at the moment we've got 5 oncologists that work here.
Oh, okay.
Soon to be 7. So we all specialise in different tumour sites. So I specialise in lung and gastrointestinal cancers. I've got colleagues that also cover those tumours, but then we also treat breast cancer, prostate cancer. So we cover all the common cancers here between all of us.
Because I know G1 where I've been is a fantastic ward that is, and I mean that it's always because it seems sometimes I get put in and I get put in other wards, but I always say, can I go to G1 because obviously you're in there. When I was getting treatment from other doctors, it almost seemed that I was like a traitor to you, that I was putting these other wards and telling them these things. And I thought, well, I need Dr. Patterson to see me. So it was that kind of thing. So you get a personal doctor, really.
Yeah, well, you've had your fair share of admissions on G1, but we can't always guarantee that everyone can get here because there's always more patients in the hospital than what we can accommodate on the ward.
Because there's plans to make the hospital bigger, so would they make the oncology and the cancer ward any bigger, do you think?
I hope so. Well, it's going to be a brand new hospital by 2030. Yes, I'm sure it will be future-proofed to deal with the increase in demand for oncology. Yeah,
2030 is not too far away, really, I suppose, when you think of it. And these places do go up. So, so... You've arrived here at obviously West Suffolk. How many years ago was it?
It was 2011, so that's 12 years ago.
Oh, 12! Wow, I didn't realise you'd been here that long. And so you have the say on all the as you mentioned about the lung.
So what we have, the formal name is an MDT, multidisciplinary team meeting. So every new patient or every patient that needs discussion because they're complicated or need help from other specialties, they'll be discussed at the MDT. So we have MDTs for every tumour site. So I'll attend the ones for my lung, colorectal, esophagogastric, etc. So there's lots of meetings. So I do 9 of these a week. And so at the MDT, you'll have oncologists, radiologists, surgeons, physicians, pathologists. So every specialty deals with cancer, and we get their expertise, and we come to a recommendation on what the best thing to do for the patient. So when you were first diagnosed, you would have gone through the MDT. We would have looked at your scans and looked at your results, and then come up with a plan for the tablet treatment that we gave you at the very start.
Yeah. So splitting your day, obviously you've just mentioned you have meetings, and then you obviously go around the wards, and then you also have your clinic. So how much of that is split into your week? What sort of percentage?
So I do 4 clinics a week. So every day apart from Tuesday is clinic day. So a typical day is a combination of clinic, MDT, ward round. The other thing I do is what's called acute oncology, which is dealing with oncological emergencies. So we have as you know from being in our unit, we get patients up 9 to 5, Monday to Friday to be assessed, and hopefully we don't need to be admitted, but we try our best. But it's a way to get patients into us directly rather than going through the emergency department. And we will go round to the ward. So any outlying patients on other wards, we'll go and see them and recommend what to do and advise our colleagues. So we try to provide the best care for our patients wherever they are in the hospital.
Yeah, I mean, you probably don't know this, and I don't know if you've ever been told, but when you come round, and it's all because when you're in hospital, it's just horrible, just laying there waiting, and it's a long day. And I mean, Pat used to come in and see me a fair bit, didn't you? But when you've been and you've spoken to us, it seems like a breath of fresh air to a patient. It really does. That's the only way I can describe it. And when you go away, you just feel 10 times better, actually, and that's with no drug.
Well, so, that's really great to hear. We're trying to do our best, and certainly many patients are really grateful and relieved when we do come and see them on other wards, because we're making the effort to come out and see them and helping them, and so that is a satisfying part of the job, is to know that it is appreciated.
Yeah, it just feels really, really good. And then first thing obviously I have to do is get on the phone to my wife and try and remember. I've written down things that you've told me, because I never remember them, and to tell her.
One of the questions that I had, every time I hear about somebody getting better, they keep ringing this bell. And we had this conversation that, there are some patients that don't ever get to ring that bell. What are your views on that bell?
I think it's a double-edged sword. I mean, I think it's wonderful for patients who are truly cured, who've got an excellent chance of cure, and they've gone through treatment. And I can completely understand ringing the bell is a way to let off their emotions and celebrate, and that's wonderful for that individual patient. But on the other hand, we have patients that we can't cure, and ringing, if they hear that bell and that they may get envious or upset, then I think we have to be careful with its use. And so, I mean, we don't have it here at West Suffolk, and I think we don't want to cause upset for patients that sadly won't be cured. But certainly whatever means to celebrate wonderful news is fantastic. The problem is that even though you think you might be cured, you can't always guarantee that. And we explain to patients they're on a cancer journey.
Yes.
It's full of ups and downs, twists and turns.
Oh, God, yeah.
And just like life in general, when you think it's going well, something you can't predict what happens around the corner. And sadly, with cancer, there will be bad, sad things that happen, even though when you think you're doing well. So I think the bell is fine for an individual patient, but perhaps not on an open ward. I think it can cause problems.
I think that was the general consensus what people were talking about, because we did a program, a podcast, and people were talking about the bell, weren't they?
Yeah.
And that was the general thing, that some didn't want to ring it because of what you said, that other people would be suffering and never ever will ring a bell, wasn't it?
Yeah.
So it was. Quite interesting that you've said exactly the same as an oncologist, that the patients, not the public, the patients have felt. So
I think it's probably wrong for the family as much as anything else as well, isn't it? To sort of, because they've been going through it, the family gets forgotten really.
I think as a cancer sufferer, I mean, I don't know how I can't talk for other people. And then you don't want to get too overexcited in case something comes along and knocks you flat on your back. I mean, my last news when I showed you, didn't I, the X-rays, that they were, really clear. I wanted to put it on Facebook. I want to put it here and everywhere. And I thought, well, no, because this could come back to haunt me. And if it grows again and. So I didn't. No, it certainly is a rocky road.
It is. You can't be complacent, and certainly I quite like using analogies in the clinic to explain things. And it's a bit like a football team. When you think you're going well and you're on a good run, then suddenly you lose a game, then things go backwards. So it can be like that.
Yeah, I remember from day one your analogies. You made it simple when you explained it in terms that I understood, and so as I said, I can only speak for me. So hopefully your other patients and all that think the same, because I mean some of them words that you mentioned earlier, they are long words, and and even I can't remember the name of my tablet properly, can I? Loratadine.
I have trouble pronouncing some of these names. You have to rename them to make it easier.
Yeah.
How important is positive mental attitude in the recovery process and treatment, do you think?
I think it's incredibly important. We do have patients that sadly are very half glass empty and very defeatist and not fighting their cancer perhaps as much as they could do. So I think being positive and leading an active life and trying to get on with life and to make the most of what you've got, and it is incredibly important. And certainly I think there's a clear correlation that the more positive patients can do better. You can't predict response to treatment, and there may be bad tumour biology and they still don't respond, but certainly everything possible to help fight the disease. And some people do make it feel like a battle, and whether it's the right term I'm not sure, but that's what we're up against. And so everything physically and psychologically that can help deal with the effects of the disease and treatment is all can help.
Yeah. There's been a lot of talk as well around certain honeys that help. Have you come across that one?
Well, it's an interesting one. I'm not aware of any particular honeys, but we know that there are particular chemotherapy drugs that are derived from plants and trees. So etoposide chemotherapy comes from the American mandrake, vincristine from the periwinkle, paclitaxel from the Pacific yew tree. So there are things out there that actually have anti-cancer properties. And I always remember a Chinese lady of mine when I was working on the South Coast who refused to have chemotherapy for her lung cancer, went back to China, and then 3 months later came into clinic, had an x-ray, and the lung cancer was incredibly smaller. And I looked at her and said, "What, you've been having treatment somewhere else?" And he said, No, I just had this special tea. And she, out of her handbag, pulled out this bag of tea leaves, and it was some weird Chinese medicine. I have no idea what it was, but it just shows there are natural things out there that can have amazing results. And what we have to be careful is that distinction between what is true anti-cancer treatment from what could be phony treatment or things with false claims. And the problem is patients understandably get more desperate when things are not going well, look for everything possible out there, and the internet is a minefield of things out there, good and bad information, and you could go down the wrong bad pathway and get given absolute rubbish for which there's no proven evidence. But there's always going to be anecdotal evidence of things that might help an individual patient. So I'm not at all against complementary alternative treatments if it helps patients feel better. And if there was an added bonus, it was going to do something amazing, then that's great.
I remember my sister-in-law had breast cancer, and she was prescribed, well, not prescribed, but was told about this honey that was meant to do something to her blood cells to help her have her treatment. Yeah, well, it
might help improve the blood count. There are there are natural things. There are certain things that apparently can increase the platelet count. So things like pomegranate and papaya apparently can help that if it helps tolerate the treatment better. And then I'm all for that.
Right.
But then, of course, there are so many different kinds of cancers, aren't there? As we know, because I remember telling you that my friend, her son was working on a new cancer tablet for the lung, and I can't remember the name of it, but I mentioned it to you, and you had heard of it, and that one wouldn't have treated what my symptoms were, you know.
No, I mean there are now more than probably 10, at least more than 10 types of your type of lung cancer, for which there are different targeted treatments or immunotherapies that can provide amazing results. And we may not be able to cure stage 4 cancer, but if we can make it a chronic illness and live with the condition for not just months now, but for many years, several years, then that's a significant step forward to make it like a chronic illness.
Yeah.
Just one more thing. When you're a cancer patient, can you ask to go on cancer trials?
Yes, absolutely, if there's something available. And certainly we do our best to mention any available trials that are available. We do trials here at West Suffolk, but a lot of the more complicated trials are either done up the road in Cambridge or go down to London, or sometimes further afield, Leicester, Manchester. So there's always possible trials somewhere in the country, but then there may be more travelling, and that can be inconvenient. And if we've got a good standard treatment available, if it's easier, just crack on with that and save a trial for later on. But yes, that's an important part of how we learn. So like the drug that you're on, Martin, we know that works because from the clinical trial done a few years ago. But what we want to do is improve things further and look for new drugs and compare it against what we're doing already and see if that one's better. So that is an important part of being an oncologist, is our clinical trials.
Yeah. Well, you said to me, didn't you, that 20 years ago I'd have probably had about 3 months because there wasn't the drugs around that there is now. And, so it just shows you the advances they've made with all these drugs and medicines. It's fantastic.
No, absolutely. And certainly lung cancer now, before, yes, patients would be lucky to make it to a year even with chemotherapy, but now we've got groups of patients like yourself with a targeted treatment that are now living for a number of years, and with the immunotherapy drugs available for some patients, 1 in 3 are now surviving to 5 years and beyond, which is a truly incredible advance and a game changer from where we were not that long ago.
Well, as I told you before, I want to be 6-7 years, so and that they'll remember me for being that person. So that's my PMA.
Good.
So some of the questions. Well, I mean, we, as I said, we put it on the forum. We had a forum, and we got asked some questions. One of the first ones was, do you think the visit of pets is good for long-term cancer patients?
Wow, I think
that's a curveball, that one.
Yeah.
Well, I think, again, if it helps psychologically, then absolutely. Yeah.
Well, I don't know if you remember when I was in G1, my little dog came in.
Yeah.
There was a certain room, because we brought Benny round, and because it had patio doors on the room I was on, my little boy, it just pepped me up so much, and that was the reason for asking that question. But I didn't know, because I know you did stroke him and all that. And,
we love it. It's great. It's great for the ward round seeing.
Yeah, because I know they do go around other wards, don't they, dogs?
I think occasionally, yes.
Not the cancer ones, but
No, I'm so obviously. With hygiene for animals and things, you have to be a bit careful in the hospital. But no, I mean, I think like what happened to you was absolutely fine. And if it helps improve your well-being and brightens up our ward round, then...
Oh, God, it really did brighten up my day, I've got to admit. So, and even when Pat came in, it brightened up my day.
Oh, good.
I didn't stroke you, though, did I? Now, you have answered this question earlier, but I think just because it got asked, I'd like to ask it again. So, how long did you take to qualify for treating, the cancer? It was from the start to the finish. It was how many years?
So, I came into oncology as a registrar in 2001. So I became a consultant in 2009. That's like the typical time it takes normally from starting to finishing the oncology training. Yeah.
Okay. The other question, what's the difference between radiotherapy and chemotherapy?
Okay. So when we got a patient with widespread disease, what we call metastatic or stage 4, we need to enable treatment, what we call systemic treatment, that will get to the cancer in all the different places in the body. And so the most commonly used systemic treatment is chemotherapy. So imagine chemo is like a poison. They try to work on the DNA of the bad cancer cells and kill them off. Unfortunately, chemo is not that smart. It also can kill off normal cells in the body. So you get the typical side effects: hair loss, nausea, vomiting, diarrhea, increased risk of infection. Other systemic treatments are like what you're on, the what we call molecular targeted treatments. So like the drug lorlatinib that you're on. So it's very precise targeted treatment again trying to hit the cancer in all the different parts of the body. And then the other main systemic treatment we use is immunotherapy, where we're trying to utilise your own immune system to hit the cancer. Whereas radiotherapy is more to deal with local areas of cancer that are causing problems. So if you've got cancer in the bone, for example, it's very painful. You can aim radiation at that one area to improve pain control. There are certain cancers, if it's unable to be removed surgically, but could be dealt with a what we call a radical or treatment dose of radiotherapy, it could all disappear and try and cure that way. Mm-hmm. So basically chemo is for all body trouble, radiotherapy more for local.
And can you have both at the same time?
Yes.
Yeah, you can, yeah.
So in lung cancer, if it's not quite suitable for surgery, you can give radiotherapy and chemotherapy together. What the chemotherapy does, it can make the cancer cells more sensitive to the radiation to enhance the killing of the cancer cells.
Yeah, because I had chemotherapy and then I had immunotherapy. I remember the chemo, the bottom half of my body was, different to the top half of my body from all the things and the injections I was having. But immunotherapy, I didn't seem to feel anything different in my body. Okay, some of these questions are just completely, not off the track. They're all to do with what you do. Do you communicate with other oncology doctors? Do you have a WhatsApp group?
Right, well, certainly with my immediate colleagues here, we have a WhatsApp group. So at our MDT meetings that we have locally and also in conjunction with Cambridge, and there'll be other oncologists there that we liaise with. The other way to network with colleagues is going to meetings. So in lung cancer, there's an annual meeting called British Thoracic Oncology Group, BTOG, that meet once a year. They have about probably just under 1,000 delegates now. So that's a good way to network professionally and also socially in the bar afterwards. So no, you learn a lot from talking to colleagues, to share experiences and hear what they're doing and how they deal with difficult problems, and that's an important way of learning is to network.
Yeah. So one of the other questions I got asked was, obviously I'm on this loratinib and it's quite a new drug. How do you find out about the new drugs? Do you have a magazine? Do you get things that, Dr. Patterson, will you please try this? Or how does it come about for trying a new one?
Okay, well, so we do hear about new drugs that get NHS approval or through NICE, the National Institute for Clinical Health and Excellence. So they will approve, if they'll assess a new drug, and if it gets approved, then we get notification that it's ready to be used. You learn from other colleagues about what drugs are available from the drug companies. They might email us or notify that their drug is now available to use. Yes, and journals is a way of keeping up to date with the latest advances. The problem is that when a study gets published, it takes time before it gets NHS approval. So it may be a lag of a year or so between seeing the amazing result and then before you actually finally get your hands on the drug. So there is that process that does take time. Sometimes things can be fast-tracked. If a drug is really good, they will try and get it through more quickly.
Yeah, because you said I think I was the second person to use the one that I'm on, and it's just I just find it fascinating, all these new things they keep finding and will keep finding, because and that's why obviously they have all these things on TV, give money for the charities and all that, because that's what they're investigating in and all that. So do you get involved in anything like on new drugs or give people advice?
We will do clinical trials of new drugs. So certainly we can get experience in using these things, hoping that they work. It is a huge minefield out there, and I struggle to keep up with everything going on. There are places doing trials with drugs I've never heard of, and so you've got to wait for the results of the study and then see whether we can use these drugs. But we want to do the best for our patients, and as we said earlier, trials are always an option for our patients if there is something available, but we can't always guarantee a trial locally or relatively nearby.
Martin doesn't do anything in halves, and he goes straight in at stage 4. So he's gone through stage 1, 2 and 3 without noticing anything. Is that normal? Does that happen often?
Sadly, it is very common because there are certain cancers where it's more obvious if it's earlier stage. So a breast lump might be easily palpable or become visible. Melanoma or skin cancer, you can see it. Yeah. But lung cancer, gynae cancer, pancreatic cancer, they're all inside the body, and to start off with at the earlier stage, it may not cause any symptoms at all. Or in lung cancer, sadly many lung cancer patients are previous smokers and may have other pre-existing lung disease. They may have a cough anyway, and what is a benign cough from a sinister cough, and it can be very difficult. So there may be no symptoms at all, or very vague, non-specific symptoms for which the GP may rightly say, well, it doesn't look worrying at the moment, but over time that you lose weight or start getting more symptoms, and then you do a scan, then lo and behold, you discover stage 4 disease. So sadly, it is very common. And if we can get smarter and find ways to detect cancer earlier, and there are promising things developing, it may be not that far away from doing a simple blood test to see if there's the presence of circulating tumour cancer cells in the body that might actually tell us there is a cancer developing.
Wouldn't that indicate that they're spreading, though, if it's in the blood?
It is proportional to the amount of disease there is, but it could still be early stage disease. So a blood test for those that may be at high risk of developing particular cancers might be a way forward. In lung cancer, we're now to embark on lung cancer screening, where we do a sort of low-dose CT scan to look for signs of lung cancer in the high-risk group. And certainly looking at the American experience, lung cancer screening reduces lung cancer mortality by 20%. So if we can build an infrastructure to do that in the UK, and it is coming, then that would be fantastic.
So would a X-ray show up with lung cancer?
A CT's better.
CT's better, yeah.
It's funny because I never had any symptoms whatsoever, and I think this is what my wife is not. I suppose she is angry because we did a podcast with our wives to see how they feel, because Patrick's had 2 heart attacks and I've got my cancer. But my wife feels she's angry because she never noticed any signs that I was going to get anything, because I never felt unwell. We moved back from Benidorm. I carried on refereeing. I was singing, and I was singing nearly every single week, performing on stage for 2 hours, and it was quite, stressful. And then suddenly, after I'd had COVID in January, I get this wheeze that wouldn't go away, and then suddenly I've gone from nothing and being as fit as a fiddle to having stage 4 cancer. It was a shock, and I think my wife is really, because she never noticed no signs. So I think, like you said, if NHS gave a structure where you could go for a routine, blood just to check. And I mean, I'd always tell people if they did to go and do it, just to find out, because it was the biggest shock of my life to find out, I'd got this. But
I think there's still a misconception about blood tests, because I think people think, if I have a blood test and it comes back fine, I'm fine.
Yeah, it's only one bit of the jigsaw. You can have horrible stage 4 disease but have completely normal bloods. So it can be a useful guide sometimes. So if someone's got cancer in the liver and if the liver blood tests are abnormal, then fair enough, but they can still be completely normal.
So they're looking for other changes in the blood, aren't they, rather than the blood itself? I don't know.
So there are, you got your normal bloods, but then there are certain cancers which we've got tumour markers. So PSA for prostate cancer is quite sensitive, and if someone had cancer in the bones with a high PSA, then it's almost certainly going to be prostate cancer. Ladies that have got abdominal pain and something wrong in the pelvis, and CA125, if that's elevated, that would be very suggestive of ovarian cancer, for example. So there are particular tumour markers that we do use to help diagnose cancers. But the most important thing is to get the biopsy.
Yeah.
So you need to get a sample of the tumour and see what it looks like under the microscope. So just like with your cancer, Martin, there are different types of lung cancer now, and the pathologist is incredibly important in telling us what type of cancer it is.
Well, there was a guitarist of a pop group. He died with lung cancer a couple of months ago, and 5 months from the diagnosis. So it must have been a completely different one that I had. But of course, you hear people, lung cancer, and you think, that's the same as mine. But I have to tell my mind that no, they sadly have passed away from lung cancer, but it was a different one to what I've got, and that's how I think in my mind. So
you mentioned smoking earlier on. How much does smoking contribute to lung cancer?
So about 85 to 90% is probably smoking related. There's a group of patients who may be exposed to passive smoking, so like Roy Castle with all those years in those jazz cafes playing there with the exposure to smoke. So the vast majority is smoking related. But there's still a cohort of patients that probably account for about 4,000 to 5,000 cases a year in this country with no major smoking exposure that can still get lung cancer.
Okay.
So it would be, if people didn't smoke, it would be a relatively rare cancer.
Yeah.
But there are other environmental factors or just sheer bad luck that it happens.
And then you get somebody in their 90s that smoked all their life and not had a problem.
Yeah.
Well, I've never smoked in my life, ever.
Yeah.
No, well, there are other things out there. So there's a lot of work looking at pollution, and that is now a risk factor.
Right.
So it's not as mysterious as we used to think that non-smokers get lung cancer. It does happen. But the non-smokers, like yourself, Martin, are more likely to get a type of cancer for which we got the targeted treatment. So instead of what smoking does, it causes multiple different mutations or different ways for cancer to grow. Whereas the non-smokers might get one main mutation or driver, we call it, that is the main accelerator for the cancer. So if you block that main driver with the drugs like we've used for you, then you get better results.
Okay, excellent.
And do they? I mean, you always say that I'm quite a strong person. Do they work better on a stronger people, these tablets, or?
I think as a general rule of thumb, most oncological treatment works better if you're fitter and stronger. Having said that, personally, we got a targeted mutation, and even if the patient was a bit weaker and frail, I would still try and use a drug because there's such a good chance that it will help. And unless you're really incredibly poorly, then you may not be allowed to use it technically, but because they're so much better tolerated than chemotherapy, where we wouldn't use for someone very poorly. All things relative.
Yeah. Going back to the early days of Dr. Daniel Patterson, you obviously went into the field of oncology and cancer and all that with the lung. Were you ever going to go into any other fields of...
I did think about general practice, and I thought initially did go down that pathway, but I think I soon realised if I was doing the job in A&E, that what I really got more satisfaction from was dealing with genuinely ill patients and trying to help them and offer them something, give them hope and treat. And general practice is an incredibly important specialty. I think GPs are fantastic in what they do, But a lot of general practice is not genuinely ill people, and there's a lot of self-limiting disease and expectations beyond what's really needed for that patient. They go to the GP surgery expecting to walk out with tablets that they probably don't really need. And so I think I soon realised that wasn't the type of medicine I wanted to do. I wanted to really help those that are in trouble and try and give them hope and hopefully cure some and at least prolong their life. So that, for me, felt the right choice.
Mm-hmm. Mm-hmm. Do you self-diagnose when you get an illness? Or do you go to a doctor? This isn't one of the questions, but I just suddenly thought of it.
Well, sometimes too much medical knowledge can be a dangerous thing. You think of causes of chest pain, for example, and it's probably just a pulled muscle, but then you start thinking, oh, is it something else? So I think there's great variability in how good doctors are in seeking help from GP. Some will just be more relaxed and say nothing to worry about.
Yeah, on the chest pain one, you don't really pay a lot of attention to it until you've had a heart attack, and then of course every chest pain you get, you think, oh, is this is this related? But of course it's not.
Yeah.
So you have to learn the difference between them.
Absolutely.
Yeah.
And we see that in our patients who have had successful treatment, and then any new onset of pain or something not quite right, the automatic thought is, oh my goodness, it must be the cancer coming back.
Yeah.
And you have to sort of reassure patients. And this is all part of what we call survivorship, is living with the condition and those understandable anxieties about the disease beginning to grow again. And we see it every day in my clinic. Patients come for their scan results, and they've been absolutely fine for the last 2.5 months. And then the last 2 weeks, they've absolutely dreaded coming to clinic for the results, what we call scanxiety, which is a real big problem that we see. And then they come in the clinic room, and before you even ask how they are, all they want to know is what the scan result is. So now I just have to tell them it's all fine, and then we go back to how they are, and then the relief on their face is fantastic to see.
Yeah, I think one of the things that I read on one of the cancer sites that we follow, one patient said, I could see on the oncologist's face it was bad news. So you must have a poker face of some description.
Wearing face masks is quite useful, actually, because you can hide to some extent, hide your expression. But yeah, you do have to be a bit poker face, I think. It is difficult.
Yeah. So let's ask another question. Is it possible to reverse stage 4 to stage 1 or become cure of cancer for good?
Yeah, the answer is yes. Certainly, certain types of cancer now, patients have immunotherapy, for example, the cancer can completely disappear. They go from stage 4 to nothing. And certainly we're now seeing longer-term survivors. So in melanoma, we're seeing 40% complete response rates to immunotherapy. In lung cancer, about 30%. So we are seeing some truly amazing results that we never thought we would see in our lifetime. With chemotherapy, it can happen. So testicular cancer, lymphoma, leukemia, they can all be completely cured by chemotherapy. So what you've got is a spectrum of cancer cells. Some are very sensitive to chemo and can all completely disappear. And then at the other end of the spectrum, you've got cancer cells that won't all completely be killed off, and you may get shrinkage or stabilisation, but you can't make it all disappear. But having smarter, better treatments means that we have a better chance of being in control of the cancer, and if we can't cure it, let's at least try and make it a chronic illness and you can live with it for a number of years.
Yeah. That was from on our forum from Linny, that was. So that question. This one's from Shirley. Is it true there's a recent increase in stage 4 cancers at initial diagnosis, and if so, why?
Well, sadly that is true, and I think probably one main reason has been the COVID pandemic. Patients have been, I think there's a whole load of reasons why that's been the case. I think general practice has been stretched to the limit of what it can cope with, and patients perhaps are not seeing their GP when they should do, or they're not recognising their symptoms, realising that it could be something potentially serious. There's less face-to-face consultations, so patients not being examined, and maybe they're missing a lump or something that was there. So I think that's one reason. But the problem is, as depressing as it sounds, 1 in 2 people will get cancer.
Yeah,
we're all living longer, and we're not dying younger age from heart or infection or strokes. This is nature at its cruelest, and cancer, unfortunately, is more common as we get older in age, because the longer we all live, the more chance a cellular mistake happens that leads to cancer. So we become slightly the victims of our own success with a good healthcare service, and we're all living longer life expectancy. We will see more cancer. So in proportion, a fair amount will still be stage 4 because of the types of cancers that we're seeing. If they're silent killers, as we said earlier, then it can be difficult to pick it up earlier.
Yeah, I mean, that statistic of 1 in 2, I didn't really believe it, but, obviously it's happened out of me and my wife, but and obviously it hasn't with you, but then 2 other people in a couple could get it to even that out. But I couldn't believe the statistic at first. But the next question, now we get asked lots of questions on our different forums, don't we, from time to time, and funny enough, I did a thing on breast cancer. I'd read an article on these 2 ladies in America. The usual thing is tell people to look at themselves, and if I find a lump, go and see the doctor. These ladies had no lumps whatsoever, so it was a thing we did on that, wasn't it? But then there's all these other myths. So perhaps you might be able to clear these up. These are the last couple of questions, really. Is it possible to get cancer from a fall or a knock?
No.
It's an old wives' tale, I thought, but you're the expert. So.
I mean, it can be, you can sometimes get fractures that shouldn't happen as a first sign of cancer, but trauma itself should not cause cancer.
No. Does too much sugar or certain other foods give you cancer? More sugar than... this was a question that was asked on our forum, wasn't it?
Particularly sugar, wasn't it?
Yeah.
Okay. Well, again, the simple answer is no, because if you think of all diabetics who have high sugar levels, majority of diabetics some will get cancer, of course, but not all diabetics get cancer. So I think that is a myth. Diet in general, so we know certain cancers like bowel cancer is more common in developed countries, and processed foods and things like that probably do have an element to play there in leading to bowel cancer, for example. But sugar itself, I would say no.
Okay. My last question, can you be born with cancerous cells?
Well, there are genetic causes for cancer. It'd be very unlucky to have it as a newborn baby, but it does occasionally happen. But certainly a fair proportion of childhood cancers may have a genetic element. And even into adulthood, there are certain cancers like bowel and endometrial, for example, breast cancer. There are certain genes. That means you can develop cancers at a younger age, so in your 30s, 40s, 50s, rather than older age. So overall, probably about 10% of all cancers might have a possible genetic cause.
You hear of babies having to have blood transfusions and things like that, don't you? And that's why I think the question was asked. Of course, there's one more important question that I have got to ask you. What do you do to relax?
Well, I mean...
You have to get away from...
You do, and work-life balance, and I have a wonderful wife and 4 boys that keep me sane at home, and probably I love reading, books, and sport, particularly
I do believe that you go and follow some certain football team.
Yeah, well, I've become a regular at Portman Road, watching the tractor boys hopefully push for promotion. So
I'm sandwiched here between two tractor boys now.
Yeah, that's surprising. But
I can show you my shirt now.
Arsenal, that's top of the league.
With my cannon on and rice on the back of it.
Yeah.
Well, thank you very much.
Yes, thank you very much, Dr. Patterson. That's absolutely amazing.
I think Dr. Patterson's been really honest, hasn't he?
Oh,
with
yes.
all his answers and all that, and that's all we could really ask for. And have you enjoyed it?
it's been great, though. Lovely.
Good.
Thank you very much.
Yeah, and because I do believe you were interviewed on Sky once, weren't you?
I was interviewed by a Sky journalist for a pharmaceutical video shoot, so that was all very formal. Yeah, that was good fun. So, yeah.
Thank you very much, Dr. Patterson, for
thank you very much
for coming in. Thanks a lot.
A real pleasure. Thank you for having me.
Thank you. And a Happy New Year. Thank you, Dr. Patterson, once again for that very frank and open interview today. Well, as it's a special this week, we're going to have to draw it to a close, Martin.
Yeah.
It's been a great show, I think, don't you?
I've really enjoyed it, yeah.
So we'd like to thank Dr. Patterson for his involvement today. And
Yes.
we'd certainly like to wish you all a happy new year, a healthy new year, and a prosperous new year.
Definitely, and thank you to Dr. Patterson, the man who saved my life.
The man that saved Martin's life. Stay safe, everybody, and we'll see you next week
Yeah.
at the usual time. Thanks very much.
Bye, everyone.
Bye.
Bye.